Our next lecturer is Phil Shearer. Phil is an SRNA currently at the University of Akron's nurse anesthesia program. He earned his bachelor's degree from the University of Akron in 2013, graduating magna cum laude. Phil worked in Summa Akron City Medical ICU prior to anesthesia school. He is planning to graduate absolutely in 2018. Not a question there, right? Not a question. And he is going to talk to us about malignant hyperthermia.
Is this a good volume? So I should have added to my bio, my wife and I welcomed our son into the world just over 2 weeks ago. Is there really any better time? The fall semester of your senior year at anesthesia school to have a newborn? I don't think so. But jokes aside, I'm very excited to talk to you guys. I'm honored to represent Akron's program. So I'll be talking about malignant hyperthermia. Hopefully a lot of this, the key points is reviewed for you guys, but I will get into a little bit of detail as well with the pathophysiology. I do want to thank a classmate of mine, Oleg Delano, who's a student in my class who put these slides together, as well as with the help of Dr. Kelly Kahn from Akron User Program. I love this depiction on the left hand or the right hand side there, this MH susceptible patient whose anesthesia care team has chosen a primitive form of technique for him. So I'm going to try to give you some tips to pick a better technique, hopefully prevent MH from occurring in the first place. So the objectives will define malignant hyperthermia, we'll look at the triggers versus the non-triggers, we'll look at the incidence of the disease, the pathophysiology behind it, the clinical presentation, the diagnosis, some diseases that mimic it, and we'll look at how to treat it, manage it, hopefully prevent it from occurring. So malignant hyperthermia is a rare inherited pharmacogenetic disorder of skeletal muscle. It presents as a hypermetabolic response to potent volatile anesthetic agents that we use, as well as the depolarizing muscle relaxant succinylcholine. If we don't treat it quickly, we can have mortality and death within 15 minutes untreated. Some of the history, and I'll tell just a couple of quick stories on MH. Between 1915 and 1925, one particular family experienced 3 anesthetic-induced deaths during anesthesia with muscle rigidity and hyperthermia. In 1960, MH received critical worldwide attention when Denborough and Lovell reported on a 21-year-old male with an open leg fracture who was more nervous about the anesthesia than about the surgery itself, because he had 10 family relatives who had died immediately after or soon after induction of anesthesia. So they did initially anesthetize him with the then new agent halothane, and he did have signs of malignant hyperthermia, and they stopped. They halted the procedure and were able to abate the symptoms progression, and then they were able to later successfully anesthetize him with a spinal for his fracture. In the 70s, we related the masseter muscle rigidity to malignant hyperthermia. In 1975, we recognized dantrolene as the gold standard treatment for MH. In 81, we have the formation of mHOUSE, which I'll talk about in a moment. In the 90s, we related the ryanodium receptor to malignant hyperthermia, and then in the 2000s, molecular genetic testing. So mHOUSE is the Malignant Hyperthermia Association of the United States, and this is an organization that has dramatically improved the care and our understanding of this disease. Consultants volunteer their time. They're available 24 hours a day for a 2-week period at a time. You can call that number, which hopefully that is available to you guys through that app if you don't get it now. And this is real time. You can call anytime. If you do call, be prepared to give your name, your number, the facility that you're at, your email in case you do get disconnected. They will even connect you to a neuroleptic malignant syndrome specialist if that is a more likely diagnosis. So if you're ever in that situation where you're not quite sure what the presenting symptoms are telling you, if it's MH or a different sort of process, you can always call this number. So some of the known triggers, older versions of the volatile anesthetics, the ether, the halothane, methoxyflurane, enflurane. Obviously, the commonly used ones are there in red, isoflurane, DES, and SIBO that we commonly use, as well as succinylcholine. It is extraordinarily rare, but you could even have stressors such as vigorous exercise and extreme heat, which could trigger MH in susceptible patients. This is one of the most complete analyses of an MH registry that we have. This was published in Anesthesia and Analgesia in 2010. And this is reported MH cases in the United States and Canada from 1987 to 2006. And what I think is interesting here is if you see on the top line that succinylcholine, when used by itself, rarely elicited malignant hyperthermia. But when you add it in, the volatile agent, you have a very, very large spike in terms of frequency. It does appear also that succinylcholine accelerates the onset and the severity of MH also. So continuing with this registry, just looking at some of the demographics, nearly 75% were male patients, close to 70% were Caucasian, 29% had a muscular body build. They were young patients, the median age was 22, and nearly half were 19 years old or younger. This is a depiction of the porcine model, which has provided a lot of insight into the pathophysiology of the disease. On the top slide, you see a pig that was anesthetized with non-triggering agents, and then the same pig on the bottom that was anesthetized with halothane. You can see the rigidity that resulted from that. The safe agents that we commonly use, nitrous oxide is not a volatile anesthetic agent. It is an inorganic compound versus the fluorinated hydrocarbons that are volatiles. IV anesthetics, propofol, ketamine, etomidate are all safe. Locals, opioids, benzos. Non-depolarizers are safe, and I'll talk about a little later, can actually potentially even delay the onset of malignant hyperthermia. Anticholinesterases that we use for reversal, anticholinergics are all safe also. So the question, why would we even use the volatile agent if propofol is not a trigger of MH and we can also achieve general anesthesia with it? And there's many answers to that, including the agent is affordable, it's reliably amnestic, it's readily titratable, more hemodynamically stable, and we can easily measure that within the body within tidal. Although it is interesting that propofol and volatile agents both primarily work on the GABA receptors, but the volatile clearly has a neuromuscular system component that triggers MH while propofol does not. Also, incidence with recall from a TIVA is anywhere from 2 to 8 times more likely. Some of the incidence of MH ranges from anywhere from 1 in 4,500 to up to 1 in 60,000 general anesthetics. Nearly 50% of patients who experience an episode of MH have had at least one previous uneventful exposure to anesthetic triggering agents. And this is why, this is a huge key point, why a negative pre-op history when we're interviewing our patients does not necessarily rule them out for malignant hyperthermic susceptibility. So in one report, MH did not manifest until 3 hours after an uneventful desflurane anesthesia, which is very rare, typically is within the first hour of anesthesia. It's rare in infants. The youngest case reported was a 6-month-old. The incidence does decrease after the age of 50. Males do appear to be more susceptible by a ratio of 2 to 1. And there's about 600 cases of MH in the United States each year. For reasons we're not quite sure, Wisconsin, Michigan, and West Virginia seem to be hotspots for the disease. We're not sure why. But we do know that it does affect all ethnic groups in all parts of the world. Some of the associated diseases, central core, multi-mini-core diseases, King-Denborough syndrome, central nuclear myopathy. Most of these myopathies have mutations involving the ryanodine receptor gene. A link is also being explored with deaths attributed to heat strokes, where post-mortem analysis detected ryanodine receptor gene mutation. Contrary to long-held views, there is no increased risk for patients with Duchenne's or Becker muscular dystrophy, neuroleptic malignant syndrome, myotonia congenita, and myotonic dystrophy. However, they are more susceptible or at higher risk for hyperkalemic cardiac arrest from succinylcholine administration. So what I want to say here is that this is just a package insert from succinylcholine warning, but the key is to realize that this event is not malignant hyperthermia. This is hyperkalemia from succinylcholine administration. So instead of treating MH, you want to immediately begin treatment for hyperkalemia. And this is why succinylcholine we use not routinely in pediatric patients, because it's apparently these healthy children that we later find have undiagnosed Duchenne's muscular dystrophies that predispose them to the hyperkalemia event. So we usually reserve succinylcholine for airway emergencies only in this population. The genetics behind MH and defective calcium channel located in the sarcoplasmic reticulum is what makes individuals susceptible to MH. The channel is termed the ryanodine receptor. Up to 70% of families that are susceptible to MH harbor one of the causal mutations. The ryanodine receptor is closely related to the dihydropyridine receptor, which is located in the T tubules, and it controls the transfer voltage change to the ryanodine receptor. And many additional proteins are being investigated. Some of the genetics, MH susceptibility has been linked to mutations on chromosome 19 in the ryanodine receptor gene, also 17, 7, and 1. Recent estimates put the prevalence of genetic abnormalities with MH susceptibility up to 1 in 400. So the question is, MH only hereditary? Can I get it through a blood transfusion, etc.? No, you cannot get it through a blood transfusion. It is an autosomal dominant inherited disorder, so any closely related family members should consider themselves susceptible to the disease. Children of an MH susceptible individual have a 50% chance of also being susceptible. And as I was talking about earlier, even those who have had previous uneventful surgery cannot be certain they're not at risk unless they've had a muscle biopsy to confirm that. And you cannot get MH through a blood transfusion. Statistically speaking, it's actually the third exposure that is the most likely to elicit MH. Why does the presentation of MH vary so greatly? In example, why the first to fifth exposure, slow to fulminant, etc.? And the answer is incredibly multifactorial. The ryanodine receptor and/or the dihydropyridine receptor could be affected. Some families have up to 25 plus different ryanodine gene mutations. MH susceptible patients can have differing degrees of irregularities in their sodium subtype channels. Depends on the patient's age, sex, the body build, medical history, the agents that we as anesthetists use. As I said earlier, it actually has been shown we could be delaying the onset by giving our non-polarizers. This is just a depiction of the excitation, contraction, coupling, neuromuscular junction mechanism, where what I'm trying to say here is you've got both contraction and relaxation going on, which are ATP-dependent mechanisms. The pathophysiology behind MH is that it completely depletes ATP, so you get that contraction initially, and then you cannot have that relaxation, which is why they present with rigidity, muscle rigidity. So a little bit more detail with the pathophysiology. Mutations in the ryanodine receptor gene leads to an altered calcium release channel. The channel opens more easily and it stays open longer, and you have a flooding of the cytosol with calcium, which leads to sustained muscle contraction, rigidity, also stimulates the breakdown of glycogen, glycolysis, and ultimately aerobic metabolism and excessive heat production. And this is only affecting skeletal muscle, not cardiac or smooth muscle. Ultimately, this leads to acidosis, hyperthermia, ATP depletion, and sarcolemma destruction. At this point, you have an enormous release of potassium, which is where we get the arrhythmias from, also myoglobin, which leads to the renal failure, creatine kinase. Skeletal muscle is 40 to 50% of our body mass, so even small metabolic changes can produce a dramatic response. So the question, are MH susceptible individuals at risk for MH if exposed to waste gases while working in the OR? I thought this was kind of interesting. There was one case of a nurse who was cleaning up an isoflurane spill and had reported MH-like symptoms, but he or she did not get the diagnosis confirmed with muscle biopsy. On the other side of the coin, we have known anesthesia providers who are MH susceptible and have worked for years without an event. Also, volatile agent is denser than air. It will drip down to the floor where it's effectively cleared by the typically excellent ventilation systems in the OR. So it's really not preclusion for us to, if we are susceptible, be working with these agents. Also, for those taking more soon, the OSHA's acceptable OR level of volatile is 2 parts per million. So the clinical manifestations, the hallmark sign of MH includes unexplained precipitous increase in end tidal, despite our increased efforts to increase minute ventilation and bring it down. You'll see muscle rigidity, hyperthermia can be a late sign. Tachycardia, acidosis, and hyperkalemia are specific to the disease, but also could be other processes as well. Elevated CO2 with muscular abnormalities is the most common presentation. The first signs of fulminant MH are typically hypercarbia, tachycardia, and masseter spasm. Hyperthermia, as I said, could be early or late. If you have a case longer than 20 or 30 minutes, we should be attempting to do some type of temperature monitoring, preferably core temperature. Barak and his colleagues showed that the risk of dying from MH is 14 times greater in those patients where core temperature was not monitored, 9.7 times greater when only skin temperature monitoring was used. So pulmonary artery, distal esophageal temperatures, nasopharyngeal are the gold standards. Obviously pulmonary artery is not something we're going to typically do in a short, simple case, but we need to be attempting, if we can get core temperature monitoring, that's the standard. Complications increase 2.9 times per 2 degrees Celsius for the maximum temperature that was reached. On the left side here, I just have some of the timing of some of the clinical signs that you would see. And keep in mind that the presentation will be variable. It could be fulminant with instant hypercarbia, tachycardia, masseter spasm, or it could be delayed with your tachypnea, hyperthermia, and they could even arrest later and pack you. More specific signs of MH are muscle rigidity, elevated end tidal CO2, temperature elevation, rhabdomyolysis, and masseter muscle rigidity. Non-specific signs, tachycardia, tachypnea, acidosis, and hyperkalemia. The lab findings that you would see with your MH crisis patient, your ABG, your CaO2 would be extremely elevated. It's certainly greater than 60 millimeters of mercury. Severely acidotic, pH less than 7.25. Hyperkalemic, over 6 milliequivalents. Creatinine kinase would be elevated, as well as serum and urine myoglobin, which would lead to renal failure. So masseter muscle rigidity, succinylcholine administration can cause this MMR, which may be an early indicator of an MH crisis. Some have argued that it's actually an indication of inadequate dosing of succinylcholine. However, muscle biopsies revealed that 50% of patients that experience masseter muscle rigidity are MH susceptible. And I think the takeaway with this is if you're observing masseter muscle rigidity in your patient, we should be looking for other symptoms, including generalized rigidity and elevated end tidal, to see if it's leading you towards the diagnosis of MH. These are some of the other diagnostic mimics: hypothyroidism, sepsis, pheochromocytoma, cocaine intoxication, heat stroke, malignant neuroleptic syndrome, serotonergic syndrome. The number one false case diagnosis of MH is an increase in end tidal during a laparoscopic case. So if you're doing laparoscopy and you see that end tidal is precipitously rising, be checking for subcutaneous crepitus, also seeing if it responds to an increase in our minute ventilation, and that would steer you away from that diagnosis. If you've given dantrolene, if you think it is MH, and you've given up to 10 milligrams per kilogram and the symptoms are not abating, then it's likely that it's not MH. However, you can continue to give more dantrolene. There's no upper limit to that drug dosing. I'll talk more about dantrolene in a second. These are some more diagnostic mimics: serotonin syndrome, anticholinergic syndrome, neuroleptic malignant syndrome, and MH is at the bottom for comparison. And if you're not sure what the presentation is, this is when you get back to the MH hotline that you can call, and they will help you differentiate the diagnosis. I certainly wouldn't know the differentiating factors here on physical exam and what we're looking at, especially under a general anesthetic. And you can call that number and they will assist you. Half the calls they receive are not MH, as it turns out, which is okay. I feel like it's better if we call and it's not MH, then we're not sure and we did call. Dantrolene is the only known drug specifically to treat malignant hyperthermia. Aside from shutting off our agent completely, this is the number one thing we can be doing to save our patient's life. Dantrolene has reduce the mortality rate from MH from over 70% down to less than 5. The likelihood of complications goes up 1.6 times per 30-minute delay that we give dantrolene. The average time between the onset, first MH sign, and giving dantrolene is 35 minutes. Also, it's not a known teratogenic, so you can give this to our parturients. It does cross the placenta, and you will have you'll see weakness from that. So dantrolene is a high dantrolene derivative that directly interferes with that muscle contraction by inhibiting the ryanodine receptor and stopping that calcium-induced calcium release right where that mechanism is for pathophysiology of MH. The dose is 2.5 milligrams per kilogram every 10 minutes, or as needed if you need to give more. If your signs and symptoms are not resolving at 10 mg per kg, you can continue to give more, but again, you're probably thinking maybe this is not MH at this point. You want to give it rapidly for a large bore IV, but don't delay in giving it to start another IV if you do have one. It's better to give it as early as we can. Every 20 milligram vial of dantrolene contains 3 grams of mannitol, which is for renal vasodilating diuresis for renal protection. We also want to avoid calcium channel blockers. If we give calcium channel blockers with this process, you can have worsening hyperkalemia, arrhythmias, and cardiovascular collapse within minutes. The number one complication from the dantrolene administration is muscle weakness, resulting in respiratory insufficiency after you've treated them successfully. Mixing dantrolene is always a bit of an issue. It's a 20 milligram vial packaged as a powder, has to be diluted down, and it's very poorly soluble. It's difficult to mix. It's time consuming. You can warm with sterile water to help it mix faster, but again, it always is a bit of an issue when you do have an MH crisis. Each facility should have 36 vials of dantrolene stocked near the OR. An average of 30 vials is used during the typical MH crisis. If you do use Ryanodex, which is another preparation of dantrolene, that actually has less mannitol in it, so we need to be giving another diuretic, either Lasix or mannitol itself, to make sure that we have enough diuresis. Initial dose of 2.5 milligrams per kilogram for a 70 kilogram patient would come out to about 9 vials of dantrolene. This is a chart just showing you the different preparations. You have Ryanodex on the far right side there. It does have a higher concentration, 250 milligrams per vial. If you'll notice down in the price column, it's over twice the cost, which is a big setback. One study, though, did show that by using Ryanodex, mixing it only took 20 seconds to mix it versus 3 minutes for the others. So that's also something to consider. And in 2021, its 7-year market protect as an orphan drug will be up, so the price actually may be coming down soon. So the treatment for MH, if you do have a confirmed MH crisis, you're going to declare an MH emergency. You're going to notify the surgeon to halt the procedure, rapidly close if they're able to. If you're using an LMA, you probably want to take that out and intubate. You want to shut off your volatile agent immediately, get your fresh gas flows up over 10 liters per minute, and hyperventilate to get the agent off. We're giving dantrolene as soon as we can, 2.5 milligrams per kilogram. And then we want to try and cool the patient down because we know they're going to be hot, whether it's lavaging open cavities, cooling blankets, cold saline, and ice packs to the groin. We also want to treat the hyperkalemia with IV insulin and glucose, calcium chloride 10 milligrams per kilogram, calcium gluconate 30 milligrams per kilogram. We want to treat the acidosis, we'll give bicarb, but keeping in mind that if we don't hyperventilate the patient and we give bicarbonate alone, we can worsen hypercarbia, so you want to be hyperventilating. For arrhythmias, again, no calcium channel blockers, but you do use lidocaine, amiodarone, procainamide per ACLS protocol would be fine. And we want to maintain our urine output over 2 mils per kg per hour for renal protection, for the renal injury. For refractory hyperkalemia, you could consider albuterol or other beta agonists to drive your potassium down, diuretics, Lasix, Kayexalate, dialysis. If they do arrest, you can consider ECMO. Also, we want to change the breathing circuit, our CO2 absorbers we do want to change. If you have charcoal filters at your facility, those are better. Those may need to be changed hourly depending on the manufacturer. If we need to maintain general anesthesia to give the surgeon time to finish what he's doing or to rapidly close, you want to use probably a propofol drip. keep them down, a non-triggering agent. We want to monitor our end tidal, the electrolytes, blood gases every 15 minutes. It would probably be a great idea to put in an arterial line. Creatinine kinase, serum myoglobin, core temperature, and urinary output and color to see the degree of kidney injury. We also want to completely remove the vaporizer so we're sure we're not worsening the process. This is obviously an all-hands-on-deck type situation. It's impossible to manage MH with one anesthetist alone and one OR nurse, unless, of course, it's myself and Dr. Pond, and we might have a shot. No new surgeries are to start while an MH crisis is taking place, so no new cases are to go back while this is happening, so everybody's available to help. For the other OR team members, we want to be giving dantrolene as early as possible. They can be helping us to get the MH cart, calling for help while they're getting it. They can help mix the dantrolene, which is always difficult. And again, that's the number one priority when we're trying to save the patient's life. Only after the first dose of dantrolene is given can team members split up. And don't forget, we still have to help the surgeon finish or close, and no new surgeries start until this is under control. If we have a med nurse, we can assign them the job of mixing the dantrolene. We can have them preparing crash cart medications, calling the MH hotline. If we have, hopefully, more anesthesia backup, they can be placing large bore IVs to give medications, drawing labs, hanging chilled saline. Keep in mind the LR has calcium and potassium in it, so that's not doing us any favors. We can switch that out to normal saline. We want to verify the breathing circuit and CO2 absorber are changed. And we can have a cooling nurse take the bear hugger off. That's not doing us any favors either. When we can do everything we can to chill the patient down. Even if they have a normal temperature, we know that temp can spike later, so we can still continue to keep them cool. And probably a good idea to place a 3-way Foley catheter to monitor urine color, send off urine samples, and see the degree of injury. So some indications that our patient is improving. The end tidal is declining or normal. Our heart rate is now stable. Lack of dysrhythmias is obviously a good thing. The temperature is back to normal. The generalized muscle rigidity is relaxing, and we've given our IV dantrolene. Follow-up care, we can continue dantrolene 1 milligram per kilogram every 6 hours to prevent recrudescence. It does occur in 25% of patients, typically within 2 or as late as 36 hours post the initial event. We do want to hopefully get our patient to ICU after all of this, if they do make it there. We want to provide the ICU nurses with the dantrolene that we do have, show them how to mix it, show them how to give it, so that they're prepared to continue the care once we have left the bedside. And one last note on the diagnostic testing. The caffeine halothane contracture test is the most common test that we have for it. It does require a muscle biopsy from the thigh and weighing at least 1 gram, which is why it precludes small children from getting it. It's expensive. It's an expensive test, about $6,000. There's, I think, only a handful of facilities in the United States that even do this test. Some insurances, probably many, won't cover it. It is a very sensitive and specific test. DNA genetic testing is available, but only 20 to 30% as accurate. So back to pre-oping our patient and asking them before surgery if they've ever had a bad reaction. Have you or a family member ever had a fever while under anesthesia? Has anyone ever unexpectedly died? We want to remember that this does not specifically rule them out as an MH susceptible individual because they have had anesthesia before without problem. They still can be MH susceptible. And let them know that they can provide this information to us and we can improve their care based upon the information they give us. And let them know that it doesn't mean their surgery is going to be canceled because they've had an issue with it before. It helps improve their safety. So if we have confirmed that they are MH susceptible, things we can do to prepare, we can go to our machine and get our fresh gas flows up over 10 liters per minute for at least 5 minutes if you have the charcoal filters. If you don't, some of the newer machines, because they're internal circuitry, you would want to do 20 minutes up to 100 minutes without those charcoal filters. You want to get rid of the vaporizers, take them off the machine, set them aside, lock them, transport mode, whatever you can do to remove them from the machine. Remove or hide your succinylcholine, get it out of the room, because that's also a trigger. Change the circuit, the CO2 absorber, make sure dantrolene is available and not expired. Open the MH cart up, make sure you have everything that you need, and then use a Nuativa, use a non-triggering anesthetic with appropriate monitoring. If we don't use any triggering agents, they can be discharged from PACU once standard criteria has been met. Also interesting to note that dantrolene preoperatively does not help, so we just avoid the triggers. There has never been a reported case of MH-susceptible patients receiving Ativa and then having an MH reaction. So if they've received a non-triggering anesthetic, there's never been an MH reaction in that situation. That's all I have for you guys.
Question.
Yes.
That chart that you showed about the prevalence of MH regarding the anesthetic technique, there was one incident, so no socks or volatile, so I'm assuming Ativa was utilized. So what was the trigger?
This one here.
Yes.
That's a good question. So you're saying because there was no assessment plan and
So
no
you're
follow-up
assuming
and
that it was
frequent
Ativa case. So what was that?
This was a 2-year-old patient with a suspected family history of MH susceptibility undergoing a dental procedure. So I'm not sure what that specific patient
Could be local.
received. Well, local would be,
For a 2-year-old.
For epi.
I'm not sure in that specific case what the patient received that would cause an MH reaction. It's possible that they had maybe a different process that they felt was an MH reaction, but it wasn't. And it was reported that way.
I just have one question. In succinylcholine alone, are you saying that it was 0.7%
Correct.
of all?
And this is
That's
just,
pretty low.
it's very low, but this, keep in mind, this is not comprehensive. This is 284 cases that were reported on that they did a retrospective look at what was given and what was elicited as a result. So it may not be representative of reality completely, but it's a good idea. It's a good indicator. It's a good guess. Thank you.
Do you find it necessary to keep a loading dose on family birth center if it's not on the same floor as your operating room?
I'm sorry, one more time.
A loading dose of dantrolene, do you find it necessary to keep it on a family birth center if it's not on the same floor as your operating room?
I would think it's a good idea to have it close by. Yeah, wherever you are.
Every anesthetizing zone should have its own theoretic MH cart, or MH accessible.
Everyone else has a standard, and I think that dantrolene is supposed to be available within 10 minutes of the anesthetizing location. But not positive, I have to go back and look it up, but there is a standard.
And I'm sure that's policy varies from facility to facility, but yeah, there should be a.
Everyone needs to know where their MH carts are. Thank you.
Thanks.